This
in which the
conference
patient
will now
undergo.
be recorded.
So the three reactions are shock, impact, and resolution. So the first, after eye loss, the patient, the first very reaction will be shock. They will undergo in deep shock. They don't like to come out. Just they like to stay in alone in a dark room. They don't want to go outside because the people, what they will think, how will be the appearance of him. So there will be deep shock. The patient will go in deep shock. After that, the impact. So all the impact will be initially negative only. Whatever you tell the patient that nothing will happen, your one eye is fine, other eye, one eye is only damaged. So then also they will not be understanding. They will all the impression will go in negative. So third one, after recovering from these two, shock and impact, they will find for the solution. So in the first few days, few months, they'll be in the previous shock and impact. So they'll not be understanding anything. So after that, after recovering from these two reactions, they will find for the solutions. What to do now? Eye is lost. Now what can be the solution for it? So they will be finding for the solution. So we need to understand when the patient comes to us in which stage he is. So while taking history, how he lost eye, uh, how the patient is behaving to you, how much he's, what is the conditions, psychological conditions of him. So everything you need to be understood first, and after that only you need to go. If the patient directly come and you will tell her this is a prosthesis and you need to go for the prosthesis, so the patient will not be understanding, right? So first you need to understand the patient. First you need to build a good rapport, good relation with the patient, and after that only you need to go for the prosthesis part. So now from here, the basic topic about anophthalmic socket. So socket means where the eyeball sits. Okay, so the groove in your eye, the the four bone, the frontal, inferior, and superior nasal temporal. So the four orbital bone surrounds and make a groove, right? Groove means a hollow thing. So where the eyeball sits, where the eyeball stays, so that part is called as the socket. Okay, so that socket will always not be same. So they are grading of anophthalmic socket. So there are 5 grading. Okay, so anyone, if any of the patient comes to you, always the outcome will not be same. All the patient socket will not be same. So understanding about the grading of socket is very important. If you don't understand about the grading, if you don't know which grading it is, you cannot tell the patient, you cannot counsel the patient how much will be the outcome, right? So understanding this is very important. So in this slide I'll be telling you about the 5 grading. If any doubt, if anyone doesn't understand, please record back. So first grading is like, if you see, it's a grade 0, means well upper fornix, deep lower fornix, deep upper fornix, the implant is central, everything is fine. So this is considered as grade 0. Grade 0 means good, well formed fornix, well fitted implant, centrally placed implant. So that is called as the grade 0 socket. After that, grade 1. So just you compare from the first picture. So this is grade 0 and this is grade 1. Do you see any difference between these two pictures? So if you see, this fornix is deep. Fornix means the place, the gap between the your eyelid and the bulbar conjunctiva and the fornicial. The gap between the bulbar and fornicial conjunctiva is called as fornix. So there can be 4 types: superior fornix, inferior fornix, this is the nasal fornix, and this gap is called as the temporal fornix. So there are 4 types of fornix. So now you compare the first picture and second picture. You see any difference? So you can see that here the fornix is deep, but if you see here, the upper fornix is fine, it's deeper. But what about the lower fornix? Lower fornix is shallow. So it's a grade 1 contracted socket, grade 1 anophthalmic socket. So the outcome of the prosthesis here in grade 0 and grade 1 will not be always same, right? So I think everyone getting it. So grade 1 and grade 0, you see the difference. And after that, grade 2. So what happens in grade 2? Grade 2, if you see the upper fornix and lower fornix, both are shallow. In grade 1, only the lower fornix was shallow, upper fornix was fine. So it is graded as grade 1 contracted socket. In grade 2, the lower fornix is also shallow and upper fornix is also shallow. So it will be called as grade 2 contracted socket. Now grade 3. So in grade 3 contracted socket, there are 4 fornix. All the fornixes is shallow. There is no upper fornix, no lower fornix, nasal temporal. So everything, all the fornixes are shallow. So now grade 5. So in grade 5, what happens? Contracture of all fornix and the horizontal palpebral fissure is also shortened. If you see the horizontal palpebral fissure, so it will be shortened in compared to the normal eye. In all this grading, the horizontal palpebral fissure will be same as normal eye. But in grade 4, along with grade 3, all the contracture, there will be shortening of horizontal palpebral fissure. After that, grade 5. Grade 5 means after multiple attempt of the surgery, then also the surgery is failed and outcome is 0. And if you see, there is no at all place to sit the prosthesis. So it is called as grade 5. After multiple attempt of the socket reconstruction surgery, then also the contracture is present, then it is considered as grade 5 contracture socket. So if you compare all the grading with grade 0, in grade 0 there will be well fitted good prosthesis can be fitted. In grade 1, little bit fine, slight lower lid sagging will be there, but prosthesis can be placed. In grade 2, with so much of the effort, you can with the smaller prosthesis you can fit. But from here, grade 3, 4, 5, it's difficult to fit the prosthesis. So in 3 and 4, we can try for the reconstruction surgeries to expand the socket. But in grade 5, already the different multiple surgery has been done, then also the outcome is not there. So in that, a orbital prosthesis can be made. So this is about the grading. So if you understand grading, you can tell the patient while seeing only. Just you examine the socket, okay, this is the grade 1, or this is the grade 2, or this is the grade 3, grade 4, grade 5, which grading is there. In that way, you need to counsel the patient. So we can make the prosthesis, but this is the condition of your socket, and the prosthesis will not be fitted so well like normal eye, but slowly after expansion, when you put the prosthesis, there will be a little bit expansion, and slowly it will appear as normal eye. So like that, you need to do counsel. If you counsel like if there is grade 2 or grade 3 socket, and you tell that patient that sir, your prosthesis will be look like a normal eye, like your other eye, then always you will be in trouble. So you need to see which type of grading of the socket is there, then only you need to start the prosthesis. Now coming to the definitions of customized ocular prosthesis. So customized ocular prosthesis means a prosthesis where impression is taken, or a customized ocular prosthesis is always termed as a prosthesis made by a impression of a particular socket. So if you take the impression and make the prosthesis, then only it is called as customized fully customized ocular prosthesis. So in Nepal, I think we have like ready-made prosthesis, partially customized prosthesis, fully customized prosthesis, and a conformers. These are the four types where we are dealing here in Nepal. So always ready-made prosthesis, everyone is aware. I think you all are aware of what is ready-made prosthesis. Means it will come in bulk, and by selecting a piece uh, by a trial and error method we place to the patient. Partially customized means what we do, we have that ready-made prosthesis, right? But if sometimes the color is not matching, sometimes a little bit hyper is there, we can cut it, we can remove the color of the ready-made prosthesis and repaint and put give that prosthesis to the patient. So that is called as the partially customized prosthesis. But in last, the fully customized means everything from first and last step, everything you make for the particular patient. The iris painting, you make the patient sit, you paint the iris. So that is in the customized ocular prosthesis. You take the impression, you make the wax model and make the prosthesis. So that is customized ocular prosthesis. You make the patient sit and do the scleral painting, you put the blood vessels on it, so that will be termed as customized ocular prosthesis. So I think everyone is clear about the what is difference between partially customized and fully customized ocular prosthesis. So in any questions we can discuss in between the presentation also. So coming to the history part, so about the prosthesis, it was started in early 18th century only. So Ambroise Pierre was the first who uh, brought the term prosthesis, and it was discovered in 18th century. But during Second World War, when the US Army developed the acrylic artificial eye, what we are using now also, little bit it is uh, about the uh, hypophobic or hydrophilic, so that material has been changed. Otherwise we are using the acrylic artificial light which was developed during the 1943 only. So it is not new, it is an old thing which was not in practice so much. Some previously the army were in the when the army were in the uh, wars, so that time they used to lose their eye, and for them the prosthesis were made. So it was not for the like medical line. So slowly it came uh, in medical line. After that the slowly it came to our ocular field. So this is not a new thing. So now coming towards the indications. So what are the indications which where the custom ocular prosthesis plays a role? So if it is a anophthalmos, if it is a microphthalmos, if it is a phthisis bulbi, if it is a disfigured blind eye. So in these cases, if it is there, we can fit a customized ocular prosthesis. So anophthalmos. So again, the anophthalmos can be acquired and congenital. So acquired means if it is a surgically removed or by trauma the eyeball is removed, so that is called as the acquired. So in acquired cases directly we can go ahead by fitting the customized ocular prosthesis. But what happened to the congenital part? So congenital means since birth only the eyeball was not growth well, the few contents of eyeball was there, or sometimes total contents of eyeball was not developed at all, so that will be considered as congenital anophthalmos. In that cases you think directly fitting a customized ocular prosthesis will play a role? No. So in these cases it will not only be the cosmetic part, but it will be the like uh, in that cases we have to first expand the socket. So if you see the difference between both the eyes, the horizontal palpebral fissure is shortened because the other eye is developed and the fellow eye, the disfigured eye has, because the eyeball was not there, so it is not developed so well. So in that cases, what we need to do, we need to place the conformer, we need to expand the socket, and after that only we can fit the prosthesis. Then only the prosthesis outcome will be nice. It will look similar to the fellow eye. So in acquired, we can directly go ahead with the prosthesis. Now coming towards the microphthalmos. So microphthalmos means generally it is also a congenital defect. So how it is an anophthalmos and how it is a microphthalmos. In microphthalmos, few parts of the eyeball is not well developed, or but in anophthalmos, total contents of the eyeball is not present. So in microphthalmos also has three types: mild, moderate, and severe. So in mild microphthalmos, if there is a visual potential, we need to send for other rehabilitation part or surgical interventions or low vision, anything we can send it. So it is not our part. It in this prosthesis cannot be fitted. So coming towards the moderate and severe. So in moderate and severe parts where the visual potential is nil, in that cases we can go ahead with the prosthesis. So in where the visual potential is nil, if you check the PL and there is no PL is negative while testing, so in that cases we need to explain for the cosmetic part and we can go ahead with the prosthesis, fitting the prosthesis. So now two things: phthisis bulbi and disfigured blind eye. Both are blind eye, right? So what's the difference between this? So most of the time I have seen the diagnosis are made wrong. Sometimes it is written blind eye, sometimes the normal eye, sometimes disfigured blind eye is written as phthisis bulbi. So what is the main difference between phthisis bulbi and disfigured blind eye is phthisis means shrunkening of the eyeball. So shrunken means the eyeball is narrowing down. If there is no visual potential, if your eye is not working, so what happens? It contracts. So or it shrunkens down. So if the eyeball is shrunken down, if it is narrow down, so that will be termed as phthisis bulbi, right? So in that cases we can directly fit the prosthesis. No need of surgery because already the place has been covered, the place has been made. So directly we can go ahead with the prosthesis. But in disfigured blind eye, where the due to any RD surgeries or due to any trauma, if the or glaucoma, so if you think the visual potential is nil, now the vision cannot be brought down and the cornea is also not clear, so patient will ask for the cosmetic things. So in that cases you can counsel for contact lens, also cosmetic contact lens, or you can, if the patient doesn't want to remove daily or they feel that contact lens is not, I cannot handle contact lens, so in that cases the prosthesis can be placed. So in that case we have two options: we can directly go for the scleral cell, or we can send for the evisceration surgery and after that we can place the prosthesis. So that can be decided by the patient also, and you can suggest in between. So you can suggest the two options: either you can go for the scleral cell or you can go for the surgery and after that the prosthesis. So what's the difference between that? In some of the cases, if the patients are so much sensitive, so if you make a scleral cell, the patient cannot tolerate, or patients might complain of pain with the prosthesis or watering with the prosthesis. So in that cases we need to send for the surgery, and after that only we need to fit the prosthesis. So that sensation can also be checked by palpating. If how we check digitally the intraocular pressure, so in the same way in the fourth quadrant we can palpate the eyeball and we can check for the sensation. So if you think, if the patient complains that pain is not there in that, so that can be your good case to go for the scleral cell. But if while pressing, while palpating the eyeball, the patient complains, no, I have pain, I have severe pain. So for that cases, we can send for the surgery, and after that, after evisceration surgery, the prosthesis can be made. So that's the major difference between this. So if you make the diagnosis, if you see the patient and you can make the diagnosis in your mind, then only you can suggest the patient, you can give the right suggestion to the patient. So now coming towards the type of prosthesis. So already I have told you about the types: custom ocular prosthesis, ready-made prosthesis or stock eye, and the one is the partial customized prosthesis. So these are the three parts which are practiced in Nepal. So again, the cost, if you go in detail about the custom ocular prosthesis, the custom ocular prosthesis is again divided into custom made scleral cell, hollow prosthesis, and iris painted cell. So we have again classified custom ocular prosthesis in the different parts. Other is the orbital one. So orbital is again divided into a spectacle mounted and stick on skin. So what is orbital prosthesis, that I will be discussing in further slide. So custom ocular prosthesis, everyone I have told you in the previous slide, custom ocular prosthesis means like taking the impression and making the patient sit in front of you, painting the iris by seeing the patient, making the blood vessels. So everything doing live by making the particularly of that patient. So in that way, so that is called as the custom ocular prosthesis. But what is custom scleral cell? So I think this can be a new term for us. So scleral cell means like, why scleral cell? Because we are covering the sclera also along with the cornea. So scleral cell means the thinnest cell. So if you see here in the picture, the thickness of the prosthesis with the caliper is less than 1 mm. If you see the caliper, it is less than 1 mm, about 0.8 mm. So the main difference between the custom ocular prosthesis and scleral cell is the thickness. In a common term, the main difference is the thickness. The custom ocular prosthesis have like 3 mm thickness, 3 to 4 mm thickness will be there, but in scleral cell it is designed in such a way that thickness will be so less, and thickness will be less than 1 mm or about 1 mm. So in which cases where the eyeball is not shrunken totally, so in that cases the scleral cell plays a great role. Where the patient doesn't want to go for the cosmetic contact lens, they don't want to handle the cosmetic contact lens, so that scleral cell can be the alternative for it. Coming towards the stock eye. Stock eye, I think mostly here in Nepal is most of the eye hospital practice this stock eye, ready-made eye. So ready-made eye comes in a bulk. By a trial and error method, what we do, we see the socket and we see the color, and slowly we feed the patient and remove it, we feed the patient and remove it, by a trial and error method, which will the best matching to the other eye, to the normal eye that we give. So that is called as the ready-made prosthesis. So you can see the difference between the two in the two picture. The first one is with the ready-made prosthesis and the second one with the customized ocular prosthesis. So always there will be so much huge difference between the cosmetic appearance, the compatibility of the patient, the life duration of the prosthesis. So everything, there will be a huge difference between a ready-made prosthesis and a customized ocular prosthesis. So now coming to us the iris painted cell. So iris painted cell is designed in such a way that the central, where the corneal scarring, or sometimes cornea is total opaque, corneal opacity, sometimes corneal degeneration is there, So in that cases, this can be placed. So this is a very thin cell, and the cornea is painted in the center. Sorry, the iris is painted in the center. So the person whose cornea is opaque, in that cases, this iris painted cell be a can play a role. But this iris painted cell is for a shorter period, for a temporary purpose. If the patient is going sometimes for the party, or sometimes for a trip, so in that cases, for if the patient want only for the short period, you can give this iris painted cell if the patient doesn't want to go for the cosmetic contact lens. So this also we have option of iris painted cell. Now the hollow prosthesis. So this can be also a new thing to us. So hollow prosthesis means we have, you can see the two prosthesis. So this is of the same measurement. The prosthesis is made of same measurement. It's a copy. Both the prosthesis are copy of each other. But what's the difference? One prosthesis is sitting down, one prosthesis is floating in the water. So this is the prosthesis which is sitting down in the base of the ball. So that is the normal customized ocular prosthesis. But the floating prosthesis, floating in the water, so that is the hollow prosthesis. So how hollow prosthesis is made in detail, we'll be telling you in the fabricating part. But in short, what's the difference? In hollow prosthesis, what we do, we separate the two surface, front surface and back surface. We cut with from the middle one, and the central portion is removed. The central portion is removed, and again the both front surface and back surface is attached together. So it's a little bit difficult, and sometimes it can break. Sometimes while making hollow, the hole can be made. So it's a little difficult one. But the patient with the deep socket, the patient in the old days whose eye is so much bigger, in that cases this hollow prosthesis play very important role. It will be like weightless, very like a minimum weight of the prosthesis will be there. Now this was about the introduction part to the customized ocular prosthesis. So now coming toward the orbital prosthesis. So orbital prosthesis and ocular prosthesis, these two are the different terms. So but the orbital prosthesis is also a part of ocularist only. Ocularist can make this orbital prosthesis too. So what is orbital prosthesis? It's like a cranomaxillary facial prosthesis. So it's like a facial prosthesis made from a silicon polymethyl siloxane material. So silicon material is the material from which we make this orbital prosthesis, and it is made for the patient where total eyeball along with the eyelid is removed. So as I have explained you in the first slide about the contracture of the socket, right? So in that contracture, all the contracture grading depends upon the fornix, right? Fornix means eyelid groove is there, eyelid is present. But what happens to the patient where eyelid is removed? If it is a cancer, if the patient has eyelid cancer and total eyelid is removed, total facial bone is removed, so what to do in that cases? So in that cases, the orbital prosthesis comes in play. So what are the indications where the orbital prosthesis can be fitted? So there are two indications. One is the post exentration socket. So exentration means it's a surgery where eyelid, eyeball, along with some parts of the orbital fat, bone, everything is removed out. So that is termed as the exentration. So exenteration is done for the patient with the cancer. So it can be due to choroidal melanoma or retinoblastoma, sometimes extended retinoblastoma, most of the times eyelid cancers, squamous cell carcinoma, basal cell carcinoma, and sebaceous gland carcinoma. So there are three types of eyelid cancers. So in that cases, if the cancers are not diagnosed in the primary stages, if it has spreaded all over the eyeball and eyelid with the some parts of the bone, orbital bone, in that cases total eyeball along with the eyelid, everything is removed out. So that is termed as the exenteration. The second indication is the severe contracted socket with bony contracture. So if you see patient, this patient doesn't had eyeball since birth, but that time their parents were not so much literate, and he was not they were not aware that the cosmetic rehabilitation can be done for those the patient with present with without eyeball. So this patient came to know about the prosthesis when he was age of 28 years. So when she came to us, so total contracture was there. The eyelid, the upper eyelid and lower eyelid was attached together like an ankyloblaphron. So it was totally attached and there was no place at all. If you see, the groove is made, so there was no place for ocular prosthesis to be fitted. So in that cases, the orbital prosthesis can be placed. So so this was about the introductory session about the ocular prosthesis and orbital prosthesis. How the ocular prosthesis is made, that comes in the fabrication part, and orbital prosthesis again has a huge process. It takes almost 5 days to make a single orbital prosthesis. If you work regularly for 5 to 6 hours daily, then it can be done in 4 to 5 days. So this was about the indications of the orbital prosthesis. So at last, this is about the introductory session. So we can discuss any questions is there, and if Bipin, if time permits, then we can go for the other presentation, and if time is not there, then we can post it for the next other day.
Sir, we have half an hour more time, so probably we can go for some case discussions.
Okay. So in any questions which we can discuss now? Anyone has any doubt?
So if any participant has any queries, you can directly ask to our presenter, or you can type it on the chat box. Sir, you can see one question in the chat box.
Yeah. So I think Gauri sir has written one question. Can you highlight the difference between the partial customized and fully customized prosthesis? So yeah, so when we'll be discussing about the fabricating parts, in that cases, I can tell you which of the steps are missed in the partial customized prosthesis. But in short, if what are the main differences between the partial and customized ocular prosthesis is, prosthesis is made from the same ready-made prosthesis. If you if you fit the ready-made prosthesis to the patient, right, most of the time the color will not be same, the color will be different, and sometimes it will be like little bit squint will be there, hypertropic, exotropic, isotropic, if something is present. So if you left like that, so that will be like ready-made prosthesis. But if you want to modify it, so in that prosthesis, what you can do, you can remove the color of the ready-made prosthesis and repaint it like how we paint with in the customized prosthesis, then in the same way you can paint it by seeing the patient color, so the color will be same. The other thing, like it is a slight exotropic or slight isotropic, so that can be corrected by little bit cutting the edges. If it is a exotropic, if you cut it like slightly nasally, if you cut, then it can appear as a orthotropic. So that things, if you modify it, and after that if you give to the patient, it will be little bit time taking, and it will be like better than the ready-made prosthesis. So that is called as a partial customized. So partial customized is made from the same ready-made prosthesis, but in that we take in consider about the color, about the appearance, and about the squinting of the eyeball. So that can be corrected in the partial prosthesis. But in customized prosthesis, everything from the impression part, the iris part, everything we do for that patient only. We start with the iris painting. So in while fabrication of the prosthesis topic will be started, in that topic I'll be telling you how iris is painted. So from that painting part, the impression part, and after that impression we make the wax, and we try to the patient. After first we do in the wax, and after that we make the final copy on the wax, and after that we copy it, and then only we make the final prosthesis. So that there will be so much of the difference, but the main difference is the partial customized prosthesis is made from the ready-made prosthesis by modifying it, but customized ocular prosthesis is totally made by ocularist from a powder. PMMA will be comes in the powder form only. From that powder we make the prosthesis. So in more detail we can, I think, discuss in fabrication part. So the other I think Gauri sir, it was clear. Okay, so the other question I think is can you highlight the care and maintenance of the prosthesis? So care and maintenance, two and three things we need to keep in mind. The first thing is about the care. So it is not so much like a care has to be like contact lens, because eyeball is not there. So the main care is that the patient should come in the regular follow-up in 6 months time for the polishing, and after that during the dispensing of the prosthesis we prescribe antibiotic drop and lubricating drop. Lubricating to use regularly, because there will be slight dryness with the prosthesis. And why antibiotic? Because while during making the prosthesis, multiple times we remove the prosthesis, we place it back, so there can be a chances of infections. So to avoid it, we give antibiotic. Sometimes we give a steroid also if we think that there is lots of inflammation has become there in the socket. So in that cases we prescribe a steroid also, but in rare cases. So the main things the patient has to take care is that if it is a so much dusty environment and like so much polluted environment, in that cases they can use sunglasses, because how much dusty will be there, that much deposits will happen on the prosthesis. So prosthesis made from same PMMA material like RGB lens. So how in contact lens you see the deposits, in the same way there will be deposits in prosthesis also. So like few deposits will not create any trouble like contact lens, because there is no eyeball, so sensation will be very less. So like few deposits will not create any problem, but there are lots of deposits are there, then it can cause infections, it can cause watering to the patient, it can make uncomfortable to the patient. So So these are the things you need, the patient has to take care while using the prosthesis. Rest everything is, I think, not so much severe like other thing, contact lenses and these things. I think any other questions?
So now we can move ahead with the cases.
Okay, so I have few cases. So I'll discuss about the cases. So I have not kept the simple cases, the cases where the normal prosthesis cannot be fitted, or sometimes the patient is not so much happy. So what can
Sorry,
be done?
so there is one new question for you in the chat box. You can answer it.
Okay, so the question is from Astha. So why iris painted cell is for temporary use? So it is a good question. So iris painted cell is also a temporary, it is like a ready-made thing. It comes in different sizes, like how the ready-made prosthesis comes in bulk, like from different sizes. So it comes in different sizes. So it can be placed over there. So the material is not like acrylic. It comes sometimes in plastic forms, or sometimes in glass mixed with plastic. So the material will not be so much uh, friendly to our body. So iris painted cell cannot be used for the longer time. And the other problem is like the discharge and these things will be collected inside if you use for longer period, because there will be no hole or nothing to discharge to come out. So it will be like a ball like thing, circular thing. So everything will be trapped inside. It will not be coming out. So if you use it for longer periods, so there can be infections, there can be discharge problem. So this is due to the material of the that iris painted cell. Is it okay, Asta?
You.
Okay, so we'll go ahead with the other presentation. So these are the few cases where normal prosthesis was. So this is the 16-year-old patient came with the complaint of poor cosmosis in right eye since 6 years, with frequent popping out of the prosthesis in past 2 years. So the complaint was the prosthesis was coming out. The customized prosthesis was fitted, but the prosthesis was not sitting well. While looking up or sometimes while doing hard work, the prosthesis was coming out. So this was the main complaint. So while taking the history, the patient complained of loss of vision in the right eye secondary to RD, rhegumatogenous retinal detachment. So due to RD, he lost his vision in the right eye. After that, in 2007, he went for the evisceration plus implant surgery. In 2009, what happens? The implant which was placed in his socket, that came out, that protruded out in 2009. So after that, the secondary implant, again the smaller size implant was placed in the socket. Again in 2009, after 1 or 2 months, the implant which was placed again, that came down. Down means it was inside only, but not at the center. It was little bit displaced or migrated inferiorly. So while doing the examination, external examination of the patient, what we noticed, with the prosthesis, the nasal gap was present, hypertropic. The prosthesis was hypertropic in appearance compared to other eye, and the lower lid sagging was present. If you see, the lower lid sagging was present while doing the external examination. Now, without prosthesis, there was a sulcus deformity, and the inferior fornix was shortening. So while doing the socket examination, the implant, the circular things you see, so it is migrated inferiorly. It should be here in the center, but it was migrated inferiorly. So while doing the examination, it was a grade 1 contracted socket, so which was not diagnosed previously, where the prosthesis was fitted and the multiple times surgery was made. Surgery was done. So in that cases, the diagnosis was not made that it is a grade 1 contracted socket. So in that cases, they were fitting prosthesis, but the prosthesis was not sitting at all. But they have not found for the reason why it was not sitting at all. So this was a grade 1 contracted socket, so the prosthesis was not fitting well. Or so we need to understand about the grading. So grading, as I have discussed in the previous presentation, so I will not be discussing more in that. So while doing the CT scan orbit of the patient, in the axial view, if you see, the implant is sitting here inferiorly. In coronal view, you can see these muscles, rectus muscles, four they small dots. So these are the four rectus muscles. This is the optic nerve. So the eyeball sits between all these four rectus muscle. If you see, this is a normal eyeball. You see the four rectus muscles, and this is a oblique muscle, the smaller one. So this eyeball sits between the four rectus muscles. But the implant was also placed in the same place, but now it is displaced downward and sitting in the inferior orbital bone. So in CT scan, this was the difference. So now coming to us the option. So what was the options for the patient? So the first option was to remove the implant and do the surgery, fornix formation surgery. The second, so the what can be the complication? Again, that the while doing the surgery, again the contracture can happen, and while doing the surgery, of a fat has to be placed from your mucus from your lips or dermis. So that can be, so that infection can be there. So that are the complications for this surgery. The second was to implant exchange with a porous or non-porous cell, to remove the implant and place a new implant in the center. But there again the chances of migrations can be there. So this was the complication. And the third option was only do fornix formation surgery and put the implant in the same place. But the prosthesis can be unstable while not placing the implant at the center. So what finally has been decided was orbital floor implant with FFS. So orbital floor implant is something like what we have done. We have done a 3D design. So many of us have heard about the 3D customized ocular prosthesis. So what is 3D or three-dimensional ocular prosthesis? Is 3D printed. So what we do, we have a 3D printer. So in 3D printer, what we do, we scan the normal eye and we scan the contracted eye, and the printed form of that scan comes in a plastic. In that place we made a customized implant where the hole was made, and after that a new implant was placed. So two implant was placed in the patient socket so that the implant will not, there will not be so much space, the normal implant will go down. So in the same way the 3D reconstruction was comes in place for this patient. So after this surgery, if you see the first uh, so there is no so much of the lower lid sagging of the post of first day. Now while seeing the CT scan, you see this is the implant again placed. You see the four rectus muscles, these are the muscles, and the implant is sitting well, and this the dome like thing, the other implant. So two implant was placed for that patient. If you place only one implant, the space was created, again that implant can fall down and it can be migrated. So what we have decided, to put a two implant, but not a simple implant. We have designed a customized implant for it with the help of 3D reconstruction. So for that, if you see the difference in the, this is the customized PMMA implant. So in the first presentation, the patient was with this impression. After surgery, if you see the difference, and if you see with the prosthesis. So this is the few surgical marks that slowly goes away. But if you see the first and third picture, there is a huge difference in the cosmetic outcome. So this was the case where the multiple times surgery was done and the diagnosis was missed previously, that it's a grade 1 contracted socket, and that ocularist was making only the prosthesis, but the prosthesis was not sitting at all. Now the second case. So it was a 18 years female with left eye enucleation and implant was done, and he had left hemifacial hypoplasia. Hypoplasia means, if you see the this facial bone, if you see, it's a normally placed, but here this bone is slightly, if you see, inferiorly migrated. It is not well developed. So most of the time it is a, if it is a contracted socket, if it is a congenital anophthalmos, in that cases, the if the child doesn't go for the cosmetic rehabilitation during their 1 or 2 years after the birth only, so in that cases what happen, the bone will not develop like a normally. So there will be the gap will be created between the bone and the head. So the appearance, how much better prosthesis you give, there will be, the appearance will be like hypoglobus of the prosthesis only. So this was the, and while doing the exophthalmometer, 4 mm of inophthalmos was there. So while if you see in the CT scan, there is a gap between the implant and this. So in that cases, how much better you prosthesis make, there will not, outcome will not be better. So what we have done, with the help of that same 3D reconstruction, we have made a silicone implant to fill that gap. So after surgery, what the gap was filled with that silicone implant. So now if you see, it is near about similar. So these are the, also these are also a field where ocularists can play a role, not only by making the prosthesis, they can also make a customized orbital implant by seeing, with the help of 3D reconstruction, or by seeing the image of the CT scan. So in that cases also, there is a good scope of ocularist to cope up. So this was the second case. So mostly the take home message from these two cases was, the implant migration is also one of the major things while fitting the prosthesis. So in one of the article published in Acta of Health, so there implant migration was 13% of the cases. The patient who went for the evisceration plus implant surgery, so in that 13% had implant migration. Insufficient orbital bone, like the implant size was not adequate in 10% of the cases. Exposure, extrusion and infection was in 8% of the cases, and mechanical obstruction and socket edema was in 1% of the cases. So how much easy we think the ocularistry is, always it doesn't will be so easy. So, always you will not get the same socket where the prosthesis can be placed so nicely, so easily. So it is like a, like if you drive a vehicle, and if you drive in Kathmandu Valley, and if you go to the like mountain valley where there is no highways, and you have to go in you have to like you have to drive your vehicle in the mountains. So there will be like so much difference in driving in Kathmandu Valley and driving in the hilly regions. So in the same way, while fitting the prosthesis, always the cases will not be so much easy. So the main thing is how we can correct is by, it is the diagnosis. If you make a proper diagnosis of the socket, which grading is there, any complication is there or not, anything in the history the patient has gone previously for the prosthesis or not, this if this everything if you do while before making the prosthesis, then only you can be a good ocularist and you can make a patient happy with the prosthesis. Because if your patient pay, always the patient will think that they they will get the prosthesis 100% similar to the other eye, but it doesn't happens always. So my only the suggestion is, if anyone is practicing in ocularistry, you need to have the basic theory also, because it's a artistic thing. But if you don't have the basic basic education or basic thing knowledge about the socket, always your prosthesis will not be, the patient with the prosthesis will not be happy. Most of the times while doing, like I will tell my story, like while doing fellowship in LVPI, so we were 5 in the beginning, but at the last 3 of them left, only 2 of us left in completed the total fellowship period. So it is not so much easy, it's a little bit difficult, but if you learn it, it is quite extraordinary from other fields. So any other questions, we can take it now. So Bipin, any of the questions?
Sir, can you highlight something about scope of prosthesis in Nepal? As you are in this field for such a long time, and you are one of the renowned person regarding ocular prosthesis in Nepal. So, we students are hoping about something about the scope of prosthesis in Nepal.
Yes. So according to me, there is a scope of ocular prosthesis in Nepal. Generally in tertiary hospital, where the patients with the tumors, where the patients with the cancers comes, so there always there will be a scope. Like till where the Tilganga Eye Hospital will run, there will always be a scope of prosthesis, because always there will be surgery, oculoplastic surgery will be there, the and there will be the outcome, there will be the scopes of prosthesis, like in your institute also, teaching institute. So there, like we have, I think, 2 main oculoplastic surgeon there, and I think every weekly one evisceration or enucleation is done, as per my knowledge. Dr. Gulshan, Dr. Jyoti Baba Shrestha. So these two. So like every weekly one or two surgery happens, and most of the times due to lack of our this ocularistry field there, so we fit ready-made prosthesis. Sometimes patient cannot afford it. So uh, like where the in the tertiary eye hospital generally in Nepal, I think there is a huge scope of ocularistry. I'll tell you my example only. When I came in Nepal, I'm 2 years back I came in Nepal. So in 2 year of the span, I have made more than 600 of the prosthesis in Nepal only. Like more than 600 prosthesis means like monthly 10 or around 10, 8 to 10 prosthesis every monthly I was doing. Except this lockdown, during these 2 months of lockdown, I have not done single cases. So every monthly 8 to 10 prosthesis I was making, but only of the Kathmandu Valley. Outside of the Kathmandu Valley, many of the patients were not able to come here, Kathmandu. So mainly the eye hospital placed near the border side where the Indian patients comes. So like 2 or 3 months back, I think 6 months back, I think we have started our ocularistry field in Jhapa also, Jhapa Dristhi Eye Care Center, Mechi Dristhi Eye Care Center. So there also monthly once I go, and like 10 or 12 cases per monthly I do there. Once in a month, or like once in 2 months I go there, and 10, at least minimum 10 cases they collect and keep for me, and I do it. So I think in most of the cases there in Mechi Drishti will be of Indian only, and the charges will be like different for the Indian patients. Always we charge little less for Nepali patient, and we charge little high for other country patients. So like only one ocularist cannot cover all the prosthesis field of Nepal. So there is a scope, but only the main problem is the training area. I don't see a good training place of ocularistry in Nepal. So in Drishti also, Drishti is a private hospital and they don't want to expose their quality to everyone. That might be the reason. Or sometimes there is not a so much huge patient to teach the other students, or all the patients pay there. There will be always paying patients. So we cannot learn in paying patient. The patient will not, many of the time the patient will not allow us to learn. They will tell that we have paid the money and how we can learn on us. So these are the few difficulties like in learning phase. But according to me, there is a scope at least 8 to 10 ocularists in tertiary, most of the tertiary eye hospital where the surgery, oculoplasty surgery are done, their ocularist place is there in Nepal.
Thank you, sir. With this positive note, we want to conclude today's session. I think it was really helpful for the participants, especially third year students. Thank you, sir, for your wonderful presentation and your valuable time.
Thank you, Bipin. And now in the other sessions we can do for the fabrication part, and rest of the case are left. I have not covered all the cases today only because in one day there will be huge thing, and this is a totally new thing, so I have not
Yeah.
made the burden. So the other classes can be done for the fabrication, and I have also done research in what are the uh, what are why the what are the most of the cases due to prosthesis in Nepal. So I have impact of prosthesis user in Nepal, so that classes can be done. So that we'll discuss, and we'll make a schedule. Okay, Bipin?
Yeah. Yeah, rest of the
Okay,
part
okay,
will
thank you.
again be rescheduled and recovered again. Sir, and finally, again, thank you on the behalf of Nepal Optometrician Society and me personally, and on behalf of all the participants. Again, thank you for a wonderful and valuable time. Thank you, sir.
Thank you.